prompt recognition of neonatal sepsis with investigations and treatment is essential to improve outcome of newborn. So today my class is going to be on investigation and treatment of neonatal sepsis. In my last class I had talked on definition, classification and different clinical features of sepsis. So let's see what are the investigations. Starting with lab diagnosis. Here there are some direct evidences and some indirect evidences for sepsis. Direct evidence means you are going to isolate organisms by cultures of blood, CSF or urine, and isolation of organism is the gold standard for diagnosing sepsis. But the problem is this takes a longer time, so we rely on some other indirect evidences. So the indirect markers, we do sepsis screen or even known as septic screening. Here, number 1, you do total leukocyte count, which should be less than 5000 per cubic millimeter is significant. Absolute neutrophil count less than 1800 per cubic millimeter is significant. Immature to neutrophil, that is immature is the band cells, to total neutrophil ratio, that is IT ratio, more than 0.2. Micro ESR more than 15 millimeter in the first hour, and CRP more than 10 milligram per liter. So septic screen is considered positive if any of the 2 or more than 2 of these parameters are positive, and sepsis can be excluded if 2 screens, that is 12 to 24 hours apart, are negative. Then you can say baby does not have sepsis. There are some other additional parameters for sepsis which also indicates the baby is having sepsis. If you find these findings in the investigations, then you can suspect this baby is having sepsis. Number 1 is thrombocytopenia. So many babies, they have thrombocytopenia when they are having sepsis. So this is thrombocytopenia is platelet less than 1 lakh per cubic millimeter. But thrombocytopenia can occur in many other conditions also, and also in sepsis. So this is not a direct evidence, but indirectly this can give you a hint if the baby has a clinical features. Then there are some findings in the peripheral smear, the presence of which also indicates sepsis in a newborn. So number 1 is Dole bodies. These are the remnant of rough endoplasmic reticulum which stain light blue with Giemsa stain. So in this picture you can see this is Dole bodies. Then you can see toxic granules. These are eosinophilic granules in the neutrophilic cytoplasm, and sometimes you can see the vacuolations in the neutrophils. So these are presence of some clear bubble like spaces within the cytoplasm of the neutrophil in the peripheral smear. Then number 3 is examining the Buffy coat. So examining Buffy coat is one of the rapid bedside screening test for sepsis. This is cost effective and this gives an early clue for diagnosis of sepsis. So many times where the culture is not available or it is taking longer time, then you can go with the Buffy coat examination. So Buffy coat is a thin layer of WBC and platelets between plasma and RBC after you centrifuge the anticoagulated blood, and this it can detect intracellular bacteria, fungi, immature WBCs, and then can be a screening tool. Then next is total immature neutrophil, that is band cell. If it is more than 20%, it is also considered sepsis. And many times you can do a smear of gastric aspirate. You take out the aspirate through the nasogastric tube, and then in this aspirate, if the neutrophil count is more than 5 per high power field, then this is considered sepsis. And you can do in the pus of from any part in this, even from the superficial lesions, If you do gram stain and culture, this can also give you a hint of sepsis. And if the baby is having an acute gastroenteritis, you can do stool RME and a culture. Then in early onset sepsis, there is a role of maternal vaginal swab. So maternal vaginal swab, gram stain and culture can be done in early onset sepsis to detect the organism. Now come to acute phase reactants. These are increased during inflammations and infection. So these will be C-reactive protein CRP, procalcitonin. So procalcitonin is more specific than CRP because procalcitonin is increased only in bacterial infection, whereas CRP can be increased in any sorts of inflammation, whether it is infective or non-infective. And another acute phase reactants are cytokines, interleukin 6, interleukin 1, haptoglobin, alpha-1 antitrypsin and fibrinogen. And there are certain negative reactants, that means these decrease during inflammation. These are also acute phase reactants, but these decrease during inflammation. So these will be prealbumin, transferrin, fibronectin. Now come to neurodiagnostic tests which are recommended. So number 1 is to see the nucleated RBC. So nucleated RBC is also known as erythroblast. These are the immature RBCs. And then another recommended is among the acute phase reactants, procalcitonin. Procalcitonin is a precursor of calcitonin, and this is produced in response of bacterial infection within 2 to 4 hours. So this is much better than the CRP because CRP rises only after 6 to 8 hours of the infection, whereas procalcitonin within 2 to 4 hours it rises, and it is more specific for bacterial infection, as this is not elevated in other viral infections or other inflammations. Another recommended are the cell surface markers, that is cytokines, interleukin 6, interleukin 8, tumor necrosis factor alpha, and neutrophil CD64 index is also recommended. Neutrophil CD64 index is a marker of bacterial infection. It is Fc gamma receptors. It is found in the Fc gamma receptors in the neutrophils, monocyte and macrophage also. So this is one of the early diagnostic markers, so this is recommended. Another is presepsin, also known as SCD14ST. This is another emerging sepsis biomarker for the early diagnosis. It is fragment of CD14. It is a glycoprotein. Then next is microRNAs, also known as miRNAs. This is another biomarker which is emerging, and then also a good and novel biomarker for diagnosis of sepsis. These are small non-coding RNA molecules. So where the facilities are available, you can go with these investigations. And number 6 is multiplex CRP and molecular assay can be done. This is another rapid sensitive tool for detecting pathogens and genetic markers. It is a variant of PCR. Next is gene expression profiling. So this is a molecular technique used to measure activity of thousands of genes at a time. So this will be very beneficial also. Another is metabolomics. Another is endotoxin activity assay, where you see the level of endotoxin in the blood. And number 10, serum fibronectin. So fibronectin was a negative reactant which decreases in sepsis. This is a fibronectin is high molecular weight glycoprotein, and this decreases during sepsis because of increased consumption or leakage or due to degradation. So with by these three ways, fibronectin decreases during infection. So these can be good biomarkers for diagnosis of sepsis. Now come to the management part. So sepsis is managed with antibiotic therapy. Number 2, supportive therapy is needed, and third is immunotherapy. In sepsis, antibiotics should be started on the clinical grounds because the culture report is taking longer time to come. So before you get the culture report, you should start empirically antibiotic based on the common organisms which is involved in that type of sepsis. So let's see what are the choices. So initial choice for early onset sepsis and community acquired late onset sepsis are ampicillin with the aminoglycoside. Aminoglycoside you can use either amikacin or gentamicin or even tobramycin or others. So whichever you are using in your setup you can use. Then if you suspect meningitis in these conditions, then you go with the cefotaxime and aminoglycoside. And late onset sepsis, if the baby is stable, you choose cloxacillin with the aminoglycoside. And if the baby is sick, there is a cardiopulmonary compromise in late onset sepsis, then you select cefotaxime with vancomycin. So these are the initial choice for this sepsis. Now based on the organisms, if you strongly suspect group B streptococcus meningitis, then go with ampicillin with aminoglycoside. If you suspect gram-negative meningitis, third generation cephalosporin, that is cefotaxime, and for pseudomonas, ceftazidime. And listeria monocytogenes and enterococcus, ampicillin with aminoglycoside is the choice. And staphylococcus aureus, vancomycin with the third generation cephalosporin. Let's see the dosing, intravenous dosing for these common antibiotics which you are using initially. So ampicillin 50 to 100 mg per kg per dose. In babies less than 7 days you give 12 hourly. For more than 7 days baby you give 8 hourly. Cloxacillin 50 mg per kg per dose, 12 hourly for less than 7 days. More than 7 days you give 8 hourly. Gentamicin 5 mg per kg per dose, OD once daily for all age group. Amikacin 15 mg per kg per dose, once daily in all age group. And cefotaxime 50 mg per kg per dose, 12 hourly for babies less than 7 days and 8 hourly for babies more than 7 days. And remember, ampicillin dose is higher in meningitis. Normal dose is 50 to 100. So in meningitis you can go, it is 200 to 400 mg per kg per dose. Now duration of treatment. Without focus, you give 10 to 14 days. Early onset sepsis and late onset sepsis presenting with pneumonia, duration of treatment is 7 to 10 days. If there is meningitis in either of these conditions, then 21 days, 14 to 21 days is the treatment. Urinary tract infection 7 to 14 days. And osteomyelitis or arthritis 4 to 6 weeks is the duration of treatment. So let's see the flow chart for the management of sepsis. So evaluate a baby who's having sepsis. Clinically, once you suspect, you go with the blood culture, CSF culture or urine culture. You do a septic screening, and then whatever advanced facilities if there is available you can do those tests, and then X-ray test. After that, if the culture is positive or presence of focal infection is there, septic screen is positive or CSF analysis is showing meningitis, you begin antibiotic and then treat pneumonia for 7 to 10 days, septicemia for 10 to 14 days, meningitis for 14 to 21 days. And you begin antibiotic in all babies. So after the reports, if you see the culture is negative, septic screen is also negative, there are no very big risk factors for sepsis. With few points you have suspected sepsis, but there are no very big risk factors in the baby. And then if the symptoms have resolved by 24 hours, so if these conditions are there, then you can stop the antibiotic after 48 to 72 hours. So treat 48 to 72 hours with antibiotic, and after the full reports you can stop and then discharge the baby. Okay, now come to supportive therapy or supportive treatment, which is also important while you are managing neonatal sepsis. Number one is thermoneutral zone is very important to prevent hypothermia. And then start with oxygen with the target saturation 90 to 95%, and support the breathing if required. Mechanical ventilation should be started, or maybe continuous positive airway pressure is required. So you should support the breathing, and then support the circulation. If the CRT, that is capillary refill time, is prolonged more than 3 seconds, then you infuse 10 to 20 ml of normal saline over 10 to 20 minutes. Then you can repeat this up to 40 to 60 ml per kg, but be careful you are not overloading the baby. So see for features of heart failure while you are giving these boluses. So if the baby is not improved, then you have to start with the inotropes. So if there is a cold shock, start with dopamine. If not improved, followed by adrenaline, and then after that followed by noradrenaline or dobutamine. So this should be the progressively starting inotropes. If there is warm shock, then you start noradrenaline followed by adrenaline or then dobutamine. In detail we'll talk about this when we are dealing with shock. Then number 4, avoid enteral feed in a sick child. If the baby is very sick, 1 or 2 days you start with the IV fluid. So the fluid you use is 10% dextrose to maintain the normal glycemia. Then correct the hypocalcemia, dyselectrolytemia and metabolic acidosis. Manage the renal failure, AKI usually they have along with sepsis, so you have to manage that. If there is seizure, then you control the seizure. First line or first choice should be phenobarbital in the newborn for seizure. And then if there is an active bleed, give vitamin K, and consider exchange transfusion if there is scleroderma or neutropenia or DIC. If there is DIC, fresh frozen plasma, platelets or packed cell volume is given. If there is shock, I already told you inotropes are used. Hyperbilirubinemia, phototherapy or exchange transfusion is done, and hygiene practice is very important while you are managing the baby. And treatment of anemia with the PCV is also important. Now come to immunotherapy. IVIG, that is intravenous immunoglobulin, it is not so beneficial, and this is expensive also and many times not available. So since it is not so beneficial, it's better you don't go with this therapy, but some centers they do practice this. Number 2, exchange blood transfusion is another immunotherapy. This is done only if there is scleroderma, DIC or neutropenia, because the scope is also limited. And under evaluation is granulocyte colony stimulating factors, granulocyte macrophage colony stimulating factors, and activated protein or pentoxifylline. So these are under evaluation for immunotherapy. Now complications. So mortality is quite high, the range is 15 to 40% depending upon the different types of setups and the facilities. Since the mortality is high and then complications are also more, so you have to handle the septic newborn very carefully. The complications can be septic shock, DIC, multi-organ failure which may even lead to death, endocarditis, septic embolization, another is abscess formation, and septic joints with deformities can occur, and osteomyelitis. So these can be different complications of sepsis. Now prevention, which is very important. Number 1 is very good antenatal care. Another is chorioamnionitis, that is maternal chorioamnionitis. If the mother is having, you have to aggressively manage this with the antibiotics to prevent the sepsis. This is one of the very big risk factor, major risk factor for sepsis. And per vaginal examinations, not more than 3 or more than 3 times in 24 hours. So you have to be very careful while doing the per vaginal examination. Another prevention that will be after birth will be barrier nursing. Washing hand and barrier nursing is very important. So hand washing by all caregivers is very important. So step by you have to use these steps to wash your hands. And barrier nursing, that is by removing all your ornaments like rings or watch or any bangles you are wearing, and then wear mask, you wear cap. So all these are wearing gloves, all these are part of barrier nursing. And then minimum handling is another step you need to take to prevent infection, and no unnecessary intervention. Try to do intervention as less as possible. That is pricking the babies to take out samples, doing the umbilical catheterization. So there are many interventions you do in the newborn. So try to do as less as possible. Then better management of the IV lines, you should check very carefully, and disinfection or disinfect the equipments you are using in the NICU, because these instruments can be another source for sepsis. So always be careful with the disinfecting the equipments. Since this is a very important part, hand washing is a very important part of a neonatal sepsis, let's see the different steps how you are doing. So number 1, rub the palms together like this, the way they have shown in the picture. Number 2, rub the back of both hands like this. And step 3, interlock fingers and rub hands together. And number 4, interlock the fingers and rub the back of the fingers of both hands this way. And number 5, rub the thumb in a rotating fashion so that you clean every part. And then step 6, rub the fingers on the palms of both hands. And step 7, rub both wrists in a rotating manner this way. And then after that, rinse your hand thoroughly. So this will be you have to apply these different steps while washing your hands, and every time you have to do this before touching a newborn or before entering the neonatal intensive care unit. Okay, thank you. I hope this class was useful for you. Next class, I'll again talk on some other topic in newborn. If you find my class helpful, please subscribe, like and share. Thank you.